My name is Neil Butala, and I'm an interventional cardiologist at the Rocky Mountain Regional VA Medical Center and the University of Colorado School of Medicine in Aurora, Colorado. Today I'm here to talk about procedural characteristics in real-world use of calcium modification strategies. Here are my disclosures. So several treatment options exist for calcium modification for PCI. Traditional modalities include cutting or scoring balloons, rotational atherectomy or orbital atherectomy. Recently, intravascular coronary lithotripsy was approved for use in coronary arteries in the United States. And this modality is easier for operator to use, decreases the risk of dissection and perforation, and improves PCI success compared to historical controls. However, data on the real-world use and procedural characteristics of these various calcium modification modalities is still incomplete. So today I'm going to talk about a study using the CAP-PCI registry data for all PCIs between April 2018 and December 2022 in the United States. Here we look at the primary exposure of calcium modification strategy. In particular, we look at people by whether they received cutting or scoring balloon angioplasty, rotational or orbital atherectomy, IVL, or in combination of these techniques. Our sample size here ends up being about 2.7 million PCIs in the United States over this time period. So first we're going to talk about trends in use of calcium modification strategy among patients undergoing PCI. So as you can see here, back in 2018, about 8% of all PCIs were done using calcium modification strategies. This increases to about 11% of all PCIs just prior to the introduction of coronary IVL. After the introduction of coronary IVL, this number jumps markedly to about 16% of all PCIs. IVL use jumps from about 0% to 8% in Q4 of 2022. Concurrently, atherectomy use actually decreases from about 5.4% to 4.4%. So here we see trends in use of type of atherectomy and IVL among patients undergoing PCI, broken down by rotational versus orbital atherectomy. As you can see, after commercial introduction of IVL, its use again increases pretty rapidly, and there's a decrease both in orbital and rotational atherectomy over the same time period. Notably, there is an increase in combination use of rotational atherectomy as well as IVL relative to orbital atherectomy and IVL, and that in Q4 2022, about 7.7% of all PCIs are done with rota IVL versus 0.2% of all PCIs done with orbital IVL. Again, potentially representing perceived synergy among these two techniques among US operators. Now we're going to talk a little more about procedural characteristics and use of calcium modification strategies. And here you can see on the left-hand side, calcium modification is more likely to be in elective cases. So about 51% of all PCIs done without calcium modification are done in urgent settings versus only about 40% of PCIs done with IVL or atherectomy are done in urgent settings. Similarly, on the right-hand side here, you can see in ACS, about 46% of all PCIs done without calcium modification are done in ACS versus only about 30 to 33% in IVL and atherectomy. Again, reflecting how operators usually think about planning these cases out relative to cases without calcium modification. Next, we're going to look at anatomic and lesion characteristics. So here you could see the breakdown of different types of lesions among patients who receive no calcium modification for PCI. So about 3% of these cases are surgical turndowns, 3% are left main lesions, and about 12% are bifurcation lesions, and 6% are graft lesions. If we look at cutting or scoring balloon use, it's a similar sort of breakdown in lesion type. So about 5% surgical turndowns, about 8% left main lesions, 16% bifurcation lesions. However, if we look at IVL, we actually see a slightly different distribution of lesion type. So 11% of all cases in which IVL is used are in surgical turndown patients. 14% of cases in which IVL is used is in left main lesions, and 18% are in bifurcation lesions. And only 2% of IVL cases are done in graft lesions. And this actually mimics the breakdown of how atherectomy is used as well. And so about 15% are in surgical turndowns, 16% of atherectomy is in left main lesions, 20% in bifurcation, and less than 1% in graft lesions. And finally, looking at calcium modification with multiple techniques, the lesion characteristics mirror those of IVL and atherectomy. So here you could see that lesion types treated with IVL and atherectomy, at least based on the characteristics observed in this data set, look pretty similar and distinct from those treated with no calcium modification or cutting or scoring balloon angioplasty. In looking at the breakdown of procedure time, so there's wide variation across different types of techniques here. Among those with no calcium modification, the median procedure time is about 52 minutes. It increases about 67 minutes among those with cutting or scoring balloon angioplasty. Increases about 81 minutes among those with IVL, 90 minutes among those with atherectomy, and 109 minutes among those with multiple techniques. Of note, these treatment time differences are likely confounded by the complexity of lesions. For instance, there's probably a fair number of type A lesions included in this 52-minute procedure time for no calcium modification. So there is a wide variation across different types of techniques when you're looking at all-comer PCIs. And this is where things start to change a little bit in looking at procedural characteristics. So here you can see atherectomy starts to look a little bit different compared to IVL, cutting, scoring balloon, and no calcium modification. So atherectomy is less likely to be performed at sites without cardiac surgery. So about 17% of PCIs done without calcium modification are done at a place without cardiac surgery. This drops to about 12% for cutting and scoring balloon and IVL. But only 5% of atherectomy cases are done in centers without on-site cardiac surgery. And this likely reflects the guidelines that suggest the atherectomy done in centers with more advanced cardiac surgical backup versus IVL, which does actually not have that indication. Similarly, radial access is less common with atherectomy. So about 50% of all cases using IVL or cutting a scoring balloon or no calcium modification are done radially versus only about 36% of all cases are done using atherectomy. And temporary pacemaker wire use is also more common with atherectomy given the concern for heart block with this technique, and less so in IVL, cutting, scoring balloon, and no calcium modification. Finally, use of mechanical support actually varies widely with calcium modification strategy. So among those with no calcium modification, only about 0.7% of cases use an Impella. Among those with cutting or scoring balloon use, about 1.5% are done with Impella. With IVL, about 4% of cases are done with Impella. Atherectomy, it jumps to about 8%. And then with multiple techniques, it jumps to almost 10%. So to summarize, there was rapid uptake in coronary IVL use, which led to an increase in use of calcium modification for PCI with some displacement of atherectomy. Patients undergoing PCI with use of calcium modification are less likely to have ACS or non-elective PCI. Lesion types treated with IVL and with atherectomy in real-world practice are generally similar. So IVL or atherectomy is more likely to be used for a surgical turndown, left main, or bifurcation lesion relative to use of cutting or scoring balloons or no calcium modification. And IVL or atherectomy actually is less likely to be used for a graft lesion. The main limitation here, of course, is the lack of information on degree or type of calcium based on intravascular imaging, which we don't have collected in this data set, which could explain certain differences in when one would use IVL versus atherectomy. However, many procedural characteristics of IVL are actually more similar to cutting and scoring balloons or use of no calcium modification and less similar to atherectomy. So atherectomy is much less likely to be performed at sites without cardiac surgery. Radial access site use is less frequent with atherectomy, and use of concomitant temp wire is much more frequent with atherectomy. And finally, procedure time and mechanical support use vary widely by calcium modification strategy. I thank you all for your time and look forward to continued discussion.